Good morning, everyone. My name is Jeffrey Jure, and I thank you for joining UMass Extension's Landscape, Nursery, and Urban Forestry program and the Laboratory of Medical Zoology for TikTok with TickReport live webinar series. These webinars are recorded and they're archived on the UMass Extension website, and they are also archived on the Laboratory of Medical Zoology website as well. Our speaker for this webinar series is Dr. Stephen Rich, who is a professor of microbiology and director of University of Massachusetts Laboratory of Medical Zoology. Today, Dr. Rich will speak about the 2018 and 2019 tick updates from the UMass Laboratory of Medical Zoology. If you have any question during the webinar, please type it in the question box on your control panel, and Dr. Rich will answer the questions at the end of the webinar. After the webinar, there will be a short survey. Please complete the survey before exiting the webinar. Without further ado, here is Dr. Rich.
Thank you, Jeffrey.
Yeah, Dr. Rich, it's you.
Okay, thank you very much. Show my screen, and it should bring up my PowerPoint presentation. Is that showing for everyone?
It's showing for me, so it should be showing for everyone, I believe.
Terrific. Thank you very much. And did you have something else to say?
I just saying I was going to mute myself.
Okay, great. Thank you. All right, good afternoon, everyone, and thanks again for coming. This is our, third installment of this webinar series. And again, I'm appreciative for your attendance and for the opportunity that UMass Extension gives us to talk about the work we're doing. Today is kind of a special opportunity for me because I've been asked to talk about updates from our Laboratory of Medical Zoology here at UMass. That's a proud moment for me because we get to boast a little bit or express our gratitude for all that we've been able to do in recent years and highlight some of the good work. Tell you about things that are going on in the laboratory, in particular about our tick surveillance program, passive surveillance program. So I'd like to start by just there we go. I'd like to start by answering the question that might be in some people's minds about why would the University of Massachusetts be involved in the kinds of things that we're doing. And I guess I would start that conversation by saying that that's in our charter, basically. The University of Massachusetts charter was to provide not just education, but research opportunities and outreach to the communities. And it's grew out of legislation from the 19th century that initially led to the creation of what was then the Massachusetts Agricultural College, and then subsequent legislation which set up funds to support research, mostly agriculture, but also engineering research. You may know that the Massachusetts Institute of Technology, MIT, is actually a land-grant institution, or started as a land-grant institution. And so when those institutions of higher education were set up, it was realized that those were also great opportunities to provide outreach and research support to the industries and agricultural enterprises here in the Commonwealth. And that led to subsequent legislation that set up those means to provide that outreach and that service. So really, we're built on the model that has been in place from the outset of the establishment of the University of Massachusetts, and we see it as fundamentally important as our mission to conduct this research. It's why I'm a state employee. I'm paid to conduct research and educate and outreach. And so this is how we make that contribution to our understanding of ticks and tick-borne diseases. I chose this picture of the University of Massachusetts. It's near the end of winter, but I chose it because I'm a big hockey fan, and I also wanted to boast about something else, which is that we have a world-class hockey program right now that's headed to the Final Four in Buffalo, New York. And if you're a hockey fan and/or a UMass fan, you should watch our Coach of the Year, Coach Greg Carville, and his team playing out there in Buffalo over the weekend. So that's a very one-sided plug, but I thought I'd throw it in there. So outreach is part of the land grant mission, and it's extended into county extension agents and others that sort of came before us. And we see our likeness here at the Laboratory of Medical Zoology is fitting that extension agent model. We're not part of UMass Extension proper, although we work with them clearly, as we are today presenting this webinar on their behalf. And we frequently interact with UMass Extension personnel quite regularly as well. We're not part of that organization per se, but we model our activities after it. Our lab is located in Fernald Hall, the building shown here on the right-hand side. It's an older building, and we've renovated space little by little over the years to create the Laboratory of Medical Zoology. Many people aren't familiar with the term medical zoology because I think I coined it, and what it's meant to comprise is the knowledge base for the study of zoonotic diseases, and in recognition that the study of these types of diseases, like Lyme disease and certain mosquito-borne diseases, requires special skill sets that often traverse different traditional boundaries of science. So I think it's worth thinking about medical zoology as a transdisciplinary entity that not only crosses over different disciplinary boundaries, but also includes different stakeholders. So in the research business that goes on in a university campus, very often there's a closed community of researchers that are talking to similar researchers. In our case, in the medical zoology laboratory, we're trying to remember the fact that the information that we're gathering is of great use to the public, and figuring out how to communicate that message to the public vis-a-vis our engaged outreach program is a big part of our mission. Nonetheless, the laboratory is a high-tech laboratory. We have all the list of skills and services that you see shown here that are available both for our research program, and you'll see there's undergraduates and graduate students, but also the service laboratory components. A lab isn't just described by its buildings. The more important and valuable part is obviously the people. And this is a list of the people that work in the Laboratory of Medical Zoology. There are now 4 faculty, including 1 visiting fellow from Nigeria, Fulbright fellow from Nigeria. Dr. Jean Mukherjee is the newest, that's Dr. Uche Chukwuwasha, and Dr. Jean Mukherjee is the newest member to join our laboratory full-time. She's our compliance officer. She does a lot of the institutional animal care and institutional review board, and she's also leading the charge in getting our lab accredited so that we will be the first ever tick testing laboratory to have ISO 17025 certification, the first that we're aware of. At the top of that list of faculty is myself and Dr. Guang Xu, and the lab is built on the partnership that Guang and I, Dr. Xu and I, have had since 2005. In growing the service components of the laboratory, we realized it was necessary not just to have a laboratory, but also to have an office staff to communicate the information that comes from that laboratory. And so here you see Paul Killinger and Kate Nadell and Vanessa Vilas, that staff that just do a terrific job of making sure that we are communicating information that comes out of the laboratory vis-a-vis TickReport that I'm going to describe to you in a moment, but also just on hand to answer questions about ticks and tick-borne diseases by a number of different mechanisms, either people that come to the laboratory and with their questions, or they can call in. We also run online chat tools. Again, I'll visit that later on in the presentation. And then at the core of the success of our program is the laboratory staff. Tim Daly's been with us for 3 years. He graduated as an undergrad in UMass. He's a great asset. Jay McCaffrey joined us a few years ago. Also great technicians from Uribe, UMass graduate. Nolan Fernandez, UMass graduate. And David is our newest research fellow. And together, these 5 people do the work of 25 people in some cases, and are just highly skilled, highly professional, full-time employees that without whom the work I'm going to describe here would not be possible. At the bottom of that list is this, on the left-hand column, are the graduate students who are involved to varying degrees with TickReport and other service aspects. I put them there because the work that they're doing, particularly the work that, for example, PhD candidate Pat Pearson is doing, is really cutting-edge work on coming to a better understanding of the pathogens and the ticks associated in these disease transmission models, and having the graduate students work in the context of the service laboratory, and having the service laboratory sit within what is a very robust research program, I think works to the mutual benefit of both. On the right-hand side, you see our webmaster, Jaron Stenquist, a private contractor that's developed our web, and also a list of past and present undergraduate assistants that work in the laboratory. So just to give you some idea of the, you know, the quality and the quantity of people that are working here in the lab. So the laboratory was designed and created as a research laboratory, and then in 2006 we started to provide this TickReport testing service as it was done actually in conjunction with UMass Extension at the time, and from that it's grown tremendously into a valued service by a number of state, town, and local health agencies. 40, I think we're almost up to 50 towns here in Massachusetts that partner with us. We have federal contracts with National Science Foundation to test mosquitoes and ticks from 47 terrestrial sites across the United States as part of their 30-year National Ecological Observatory Network project. And there's some numbers there showing the number of pathogens we test under those. I mentioned before that we're establishing our lab as an accredited ISO 17025 laboratory. Even before that, in keeping with the contracts that we secured from NSF, we were required to really formalize all of our SOPs, our standard operating procedures. And so, whereas, believe it or not, most research laboratories wouldn't have you know, SOPs that would pass muster from outside audits, ours do, because we had to, in keeping with the securing of that national contract. And then down there at the bottom really is what I want to talk about today, which is TickReport, which is our service laboratory that takes all of these laboratory capacities and really makes them available to the public in a way that's unprecedented and is providing unprecedented opportunities for information and knowledge. So what I'd like to start off describing is our TickReport's passive surveillance effort, which is surveillance can be done either actively or passively. In this case, it's a passive surveillance because the ticks are being sent to us as they encounter people, or vice versa, the people are sending us the ticks as they encounter them. And so that regards it's passive as opposed to us going out and trying to find the ticks and or the people. There's a number of benefits, as you'll see, to doing things this way, and the passive surveillance effort is built on this, as you see in the bubbles above. It's got a sustainably funded crowdsource model, so it's not something that relies on federal or state dollars that can sometimes be cut over time. It's inherent in the system that this is sustainable because we're building a surveillance model based on the fact that people are looking for information about their individual exposures. We tie the work to engaged outreach communications, so things like the webinar we're doing today, but also talks that we give around the Commonwealth and beyond, to garden groups and libraries and town health groups, or just about anyone that will invite us, where we can go in and tell them more about infectious disease and risks associated with tick bites. Our goal is to try to chase away some of the fear that lies behind these, the fear that comes from not knowing, and we try to introduce information that empowers people and not let people be scared by what we're showing them. We're not doing this it's not for the benefit of the enterprise, it's to actually try to change the practices that people are currently undertaking to keep themselves more safe from tick bites. And there's a huge aspect of this that's a citizen science component. I think people appreciate the opportunity to be part of many people, to be a part of the passive surveillance effort. So before going into describing what the passive surveillance is, I just thought it'd be worth giving a little basic overview of the epidemiological underlyings of this. When public health people think about environmental risks, and we can think about ticks as environmental risks because the risk of getting disease comes from ticks, not from other people. They start by first describing a set of hazards. I have an example here. And a hazard could be something, for example, like man-eating fish that are human-eating fish that are living in the waters nearby. And what's of interest from that hazard is to know what kind of risk it poses to the population. And so risk, unlike hazard, is a quantitative thing that can be measured in terms of the likelihood that that hazard is going to cause harm to individuals. So you can identify a hazard as sharks, and then the risk could be the number of people that actually get attacked by sharks. And what we would know is that that's hazard is mitigated by the exposure level. So extreme example, if you don't go in the water, you don't go in the salt water, your risk of exposure to that hazard is pretty low because the sharks aren't going to come out on land. And often, I think, although this is well understood among epidemiologists, this gets lost when we start to think about how we would go about assessing risk of tick-borne diseases. Because here, what we often account for is the hazard, which is knowing that infected ticks exist out there in the world. And then we know the risk, or we have some insights about the risk, although sometimes that can be hard to measure as well. But we know the number of people that are getting sick. So the CDC estimates somewhere in the neighborhood of 30,000 people with reported illness, and suggests that maybe the actual number is 10 times that number. So that's the risk of infectious disease. But what I would like to present to you is the idea that neither of those speak to the exposure rates, that we're missing the piece in the middle that tells us how often those hazards come in contact with people. So we sort of see what happens before the exposure in terms of the hazard, because we can go out and collect ticks and measure their infection rate. We can also look at risk because we can see people showing up in hospitals. But what my lab is trying to focus on is this centerpiece, which is to understand the rate at which people encounter those hazards and use that to predict the intended risk. So exposure in terms of tick-borne diseases comes in basically three different characteristics that we can quantify. One is, or qualify. One is to know the tick species. So it turns out that the hazards are not equal for all species of ticks. To use Lyme disease as an example, and I talked about this a bit in the last webinar, the hazard associated with Lyme disease is from ticks that are deer ticks, and not from dog ticks, not from lone star ticks, not from longhorn ticks. It really comes from one species of tick, and even within that tick species, not all the individuals are infected. So it's worth knowing what the tick species is. The second thing that would be very, very important, and every colleague I have would be quick to point this out, is it's important to know how long that exposure took place. So the tick feeding process is a very slow process that involves things coming out of the tick into the person, out of the person into the tick or the animal, and that with that process there's different rates at which the pathogens, the things that are going to make us sick, move into or out of the tick. It doesn't happen instantaneously, and it doesn't happen constantly throughout the course of a 10-day feeding cycle. There are particular times when the pathogens are going to be moving, and that's why we say that how long the tick is feeding is a very, very important aspect of measuring exposure, because pathogen transmission takes time. And then, of course, the last thing to know about the exposure is the infection status of a tick. It's not enough to know whether a tick is the right species and or whether it's fed long enough. Not all ticks are infected, and so it's very important to know whether the tick that is fed on a particular day on a particular person is one of the ticks that poses a risk because it's infected with the pathogens that are present. And so again, just to give you some perspective, only about 50% of the adult ticks, which are the ticks that are active now in the state of Massachusetts, deer ticks active in the state of Massachusetts, only about 50% of those are infected with Borrelia burgdorferi, so the cause of agent of Lyme disease. So knowing whether your tick is the right species, whether it's fed, and whether it's one of the 50% that's infected is very valuable information. With that understood, we've set up to allow or to create a model that allows people to measure that exposure risk. It's a tick-borne pathogen testing surface. It's based on a qPCR-based detection method. That is, we use molecular methods to detect the DNA of the disease-causing pathogens. It is a fee-for-service, and we measure all the other aspects of that exposure model, including feeding rate and this tick species as well. And we incorporate this into surveillance programs, including engaged outreach efforts and partnerships. And what I'd like to present at the end of the talk is that there may be actually value in this tool as a risk assessment tool for individuals. That tends to be a somewhat more controversial. So the value of knowing whether your tick is a high risk tick or a high exposure tick based on its feeding status, its species, and its infection rate, knowing if it's positive or negative. That's a somewhat of an open debate among colleagues and among agencies that are involved with speaking to these issues. And let me just give you the CDC's position on that to sort of underscore what's of concern. One is that if a tick comes back and it's positive, those positive results don't necessarily mean that that's a diagnosis of disease in a person. So it's likely, as for reasons we just described, that the tick hasn't fed long enough, or that for one reason or another, that species has not, or that tick has not made the person sick. So the CDC is concerned about creating a false impression from a positive tick result. Likewise, they're worried about a negative tick result, because the concern there is that if you get bit by 2 ticks and you only test one, and that one tick is negative, you may be misled because the testing of one tick has no bearing on the other tick. Also a legitimate concern that could lead to false sense of assurance if you're judging your tick report or your tick test to be a diagnostic or a diagnosis. What I'll say about those first 2 points is we are 100% in agreement with the CDC on these points. And because we test ticks and because we provide the results that they're concerned about, we make that clear in our messaging that we're not trying to diagnose human disease. We're trying to measure exposure risk, as I've outlined in the previous slides. So I think that's a fundamentally important thing to understand, and for people to understand why it is that we think it's important to test ticks, and yet why it seems to be that the CDC suggests that there's less value in that service. The last 2 points I would speak to: one, that the tick testing laboratories do not have the standards of other diagnostic laboratories. We're in agreement with that. Most of the newly created, so we've been doing this since 2006, most newly created testing laboratories don't make their methods openly available. They don't publish their methods. They don't publish their results, other than perhaps on an unrefereed web page where they use it perhaps as much as anything to scare people into utilizing their service. Unlike those services, we do publish our results. We do have our methods undergo scrutiny of organizations like the NSF in terms of the NEON contracts, and we subject ourselves to peer review. We try to make this as good as diagnostic testing. It doesn't fall under the jurisdiction of diagnostic testing, so no one's held to that account, but we hold ourselves to that account and to those levels of standards. So on this point, we disagree with CDC that not all laboratories have those lower levels of standards. We'd argue that we actually have a very high set of standards. And then the last point about the timing of this, that specifically that that this timing of a tick result is not likely to come within the window and it's still clinically relevant. This was written, or these guidelines were stated probably a decade or more ago, when the only people testing laboratories or testing ticks were laboratories that were also doing human diagnostics, and the tick testing was sort of an afterthought. And so the pace at which they turn around results, it might take 2 or 3 weeks. And then the CDC is correct. It's no longer clinically relevant. You would either be sick or on your way to not getting sick, having treated or not treated, long before you get that tick report back. In our case, tick report results come within a guaranteed 72 hours, very often within 24 hours. And so it's still well within the range of making decisions about when to see the doctor, what to do when you've seen the doctor, and comes far before the human diagnosis would even be possible because of the rate at which it takes people to seroconvert to that exposure. So we are in agreement with the first 2 points, but we think the latter 2, we've sort of, at least our laboratory has overcome. So where the CDC and the Massachusetts Department of Public Health and the Laboratory of Medical Zoology are in complete agreement is about the population level or the public health benefits of an aggregate of information to know about the characteristics of human-biting ticks here in the state of Massachusetts, we actually do this in all 50 states now. Because when you have all this aggregated information about the levels of exposure, you end up with what we call the passive surveillance network, which is highly valuable at figuring out where to target the efforts to try to minimize that exposure risk. So a little bit about our service. It's currently an online service. It's available to anybody, anywhere, basically. The way the service works is you go to the web page, you order a tick report. You can see the buttons there on that's a screen capture of our web page. You'll be asked for certain information about your tick exposure, where the tick bit you, what just different things about the time of day and that kind of stuff. And you can offer that information if you wish. You also give us information that allows us to contact you with the results. We never share that information, even within the laboratory. Portions of the laboratory never see the private information, because what we assign when you place your order is we assign a 6-digit order number, and then that number routes through with your tick. Once we receive your tick and reconcile it with the order number, it's just a 6-digit code separated from your private information. And then at the end, we report out the results. It goes back to your emailed a link to your private report where you can review it. I can show you an example of what those look like. And it's not just about tick testing, as I said before. We look carefully at the degree of feeding of the tick based on the shape and the size of the tick's body. Ticks grow, ticks increase in size, and the dimensions, the ratio of dimensions change as they feed. So we establish whether it's a tick that's fed for a long time or a tick that's not fed for very long. There's some pictures showing ticks that have fed for varying degrees. Here's a picture from the Tick Encounter Resource Center at URI. Very nice series showing how ticks increase in size as they grow, as they feed. And I'm here to tell you that the risk of exposure to the pathogens within that tick, if she or were infected, increase across that time series. After having established what species it is and how long it's fed, we then smash the tick up and extract whole nucleic acid from it. That's whole DNA and whole RNA, because that's going to be the substrate by which we detect whether the pathogens are present or not. So many people ask us, well, how can these tests be so accurate compared to tests, for example, used in human diagnostics? Well, the answer is quite simply that we grind up the whole tick, and so we're able to look at all the contents of that tick, including bacteria that might be in very minute quantities, and their DNA is the barcode that allows us to detect them, which is the other reason we can look at multiple pathogens within one tick. And many of the ticks, maybe half or more of the ticks, depending on the time of year that we test, are negative. They have no pathogens. But it's not uncommon for us to test ticks that might have 3 or 4. I think we even had a couple of cases where there were 5 separate pathogens in an individual tick. So it's not unheard of to see multiple pathogens within a single tick. And the data comes from these accurate, they're called quantitative PCR assays, polymerase chain assays, that were developed in our laboratory, that are published, publicly available. And in fact, we know that some laboratories now that are offering more commercial venture testing are utilizing some of our protocols to test ticks for a fee. We test ticks for a variety of different pathogens, and we've learned through the years to break this down between deer ticks and non-deer ticks. Deer ticks are the predominant human-biting tick in many parts of the country. They are also the ticks that are most associated with transmission of disease, and particularly with the agents of Lyme disease. But you can see we test for other things here as well. Babesia microti and Anaplasma phagocytophilum being at the top of that list. Talked about those in the last webinar. We also test for Borrelia mayoni, which is relatively rare pathogen, was identified in Minnesota a few years at the Mayo Clinic, and we throw that test in there. We've seen a couple positives. All of them came from that area of the country, not from here in the Northeast. We also test non-deer tick pathogens in non-deer ticks, and that's important because while non-deer ticks aren't associated with Lyme disease, they are associated with other pathogens, and while those pathogens are very rare, we recognize that it's important to test for them as well. At the bottom there, you notice that we test as well for viral pathogens. I told you that we extract whole DNA and RNA. It turns out that the viral pathogens of ticks are usually RNA pathogens that lack DNA. And so we had to develop a set of assays, first extraction protocols and assays that allow us to detect the presence absence of those RNA molecules. And I'll be honest with you, at first we thought it might not be possible because RNA is not a stable molecule in the way that DNA is. And so we thought that many ticks that would be sent to us would be of insufficient quality to test RNA. But as with our DNA tests, we have internal controls that tell us whether the RNA is of good quality or not. We basically use targets within the tick's RNA itself. And if we can detect tick RNA fragments in a tick, then we have a very, very high probability of detecting viral particles if they're present. And so we incorporate that into those internal controls into our assays as well. But we are, I think, to date, although as I say, there's a number of groups that are always following up on our heels, we are the only group that tests, only tick testing laboratory that tests for these viral pathogens like Powassan virus or deer tick virus. Here's an example of the results that you would get. This is, I'm not sharing anyone's information other than my own. Here you see the information that I provided in the right panel, which is my home address, which I don't know exactly why I'm showing that in this podcast, but nonetheless, there it is. And on the left, you see the test results, including at the top, the picture of the tick, dorsal and ventral, that I sent into the laboratory to be tested. And that's what we do to every tick, is we take the picture to document that before we smash the tick up. In this case, you see I didn't test for RNA quality, or for RNA pathogens. I did test for the standard deer tick package, and my tick passed muster with the internal controls, meaning it was sufficient quality to be able to detect pathogens. And it turns out that my tick was positive for the agents of Lyme disease, Borrelia burgdorferi, information that I was very happy to know. Okay, so that's the tool. That's the thing that we make available. And let me tell you why I think it is that everyone's in agreement that it's a valuable measure for exposure. If you consider the two methods before, so the more actively surveilling programs that were available before we developed TickReport, it would be either field sampling of ticks. This is, you go out to the field and you drag and you collect ticks, and then you bring them back to the laboratory and you test whether they're infected or not. Or you can look at human case reports. So you can go through insurance records, for example, as is being done by a number of groups now, and you can see how many people are showing up with a disease that sounds like Lyme disease, or how many, for states that do this, how many how many patients are being reported as having been diagnosed with Lyme disease. And what I'd like to tell you is that if you think about the important entomological exposure factors, or the exposure factors, like the rate at which people encounter ticks, shown there in the first row, or the infection rates among ticks, or the duration of tick exposures, those two sampling strategies have very limited value to identifying those key exposure factors. And in particular, field sampling of ticks gives you no information about how likely a tick is to encounter a person. We know areas that we can go and flag ticks quite readily, and we do so when we need them for experiments in the laboratory. But very often those are in pretty, areas that generally people wouldn't traverse. So like going through big, thick briar patches that aren't likely to be spots where people would be crawling around. So the ticks we sample there aren't reflective of ticks that may ever see people if we hadn't gone in there looking for the ticks. Likewise, while there's a direct measure of the infection rate among the ticks, because you're looking at ticks that you captured in the field, we get no information about how long those ticks feed on people on average. And as I'll show you in a moment, we know that in different parts of the state, there seems to be a different average feeding time for ticks on people, based largely probably on human behaviors. Now, human case reports are even less valuable in terms of measuring that exposure, because all you're seeing are the end results of that exposure. And so while they give someone an indirect measure of infection rate among ticks, because every sick person must have got sick from a tick-borne disease at the bite of a tick, we can't really quantitate that. We don't know if it took 10 ticks for that person to get sick, or 1 tick, or 100 ticks, or whatever. And we get no information about tick encounter rates or duration of tick exposures. So I would argue that the traditional method, which is collecting ticks, is measuring the hazard. The traditional method of looking at human case reports is measuring risk. And our method, which is the passive surveillance of human biting ticks, measures exposure, and it provides a direct measure of those key factors that we've outlined above. So setting aside for the moment my apologetics about why I think TickReport is important, let me just show you some data that we generate from this surveillance that's been ongoing since 2006. So since 2006, we've tested 54,000 ticks. That's 54,000 human-biting ticks. A small percentage of those might have bitten cats or dogs, but by and large, more than 98% of them are actually human-biting ticks. We don't preclude people from sending dogs or ticks, dog or cat feeding ticks. It's just that most of the ticks come to us from biting on humans. We have ticks from all 50 US states, although in some of those cases we know that the ticks probably didn't originate in the state from which they were sent. I'll show you that in a moment. About 40% of the ticks we receive are from Massachusetts. That's down from a few years ago when it was upwards of 55%, as you see in the table. It's been gradually decreasing, the percentage of ticks that we receive from Massachusetts. The absolute number of ticks we receive from Massachusetts has actually increased a little bit, but what we're seeing is a large percentage of ticks, or a larger number of ticks comprising our submissions are coming from outside the state. And we think that's really just has to do with word of mouth, that the word of mouth about the availability of the service was initially quite high here in Massachusetts and has trickled out in the neighboring states. And now, actually, California, shown on the list, is probably within the top 5 for the number of ticks that are sent to us. The last line there I have is that about 12%, 10 to 12% of the ticks that we receive come from Cape Cod. And that really reflects the fact that we've partnered for a long time with entities in Cape Cod to ensure that the service is affordable and available and appreciated and understood in that area, and probably more there than anywhere else in the state, and that reflects the high submission rate. So for example, we work with Barnstable County extension agents. They've got a wonderful man in Larry Dapsis that reinforces tick outreach and gets out and talks to groups about the importance of being tick safe, and puts tick testing in part of that model. We also have partnerships with Cape Cod Healthcare, which is a large healthcare agency there that subsidized ticks testing for that area of the country. And so a service that nationally we charge $50 for usually costs Cape Cod residents significantly less, usually around $15 as opposed to $50. And that comes directly from the fact that local agencies there are pitching in and helping to subsidize that service for its residents. We're looking to establish those kinds of relationships elsewhere in the state and have had successes on a town-by-town basis. So let me tell you a little bit about the results. So the passive surveillance program provides novel public health insights and allows us to assess this exposure risk. And let me show you the kinds of questions that we can answer. We can tell who's getting bit by ticks, when they're getting bit, where those bites are occurring, and what disease-causing pathogens are involved in those bites. So let me walk you through a little bit of that data now, just to give you some idea. Who's getting bit by ticks? Let me answer that question first. It turns out that virtually everybody is getting bitten by ticks. I'm sorry. Sorry, the slide's going a little bit shorter. There it is. So the age distribution of ticks is bimodal, as is the age distribution of Lyme disease here in the state of Massachusetts. So these data are just for the state of Massachusetts. Sorry to those of you that might be outside the Commonwealth right now, but the purple line that I'm showing here is actually the proportion of ticks in the age groups that you see along the bottom that were reported Lyme disease cases in, I think this data are for 2013 to 2016. And the lines below are for the incidence of ticks that were sent to us, the age groups for ticks that were sent to us, broken down by nymphal ticks, adult ticks, and all ticks in total. And what you see is that we get many more ticks sent to us from very young people and from sort of middle-aged people, and then from people in this teenage up through 30-something group, we don't see a lot of tick submissions, and that this corresponds to a decreased reporting of Lyme disease cases in those individuals. So it's valuable in that it reaffirms information that was known from the epidemiological surveillance, but it also rules out possibilities for why we see that bimodal distribution of disease, which one might have thought it might be that, well, everybody gets bitten by ticks, but only old people and young people get sick from the disease. This suggests that the rate at which people get attacked by ticks in the state of Massachusetts is not the same across all the different groups. We don't have an explanation for why that is, but these kinds of observations allow us to test those types of hypotheses. I mentioned before that we see a differential rate of feeding of ticks on people. So here in Massachusetts, in a study we did in 2014, where for 31 towns in the state, testing was totally free, we found a differential rate of tick feeding in Nantucket counties, Barnstable counties, Middlesex counties, and Franklin counties. So a higher proportion of the ticks in Franklin, Middlesex, and Barnstable were fully engorged ticks, meaning ticks that posed a greater danger of transmitting their pathogens than on Nantucket. For one reason or another, Nantucket ticks seem not to have had the same degree of feeding. We could speculate that that may be that that at this time in 2014, the information about ticks or the awareness of ticks was greater on Nantucket, and so people were doing more frequent tick checks of their bodies or their children's bodies, and were pulling the ticks off in quicker order. If that's true, these kinds of data allow us to tell where we should be concentrating our message or telling people to be aware of ticks and make sure that they end up looking more like Nantucket than they do like these other counties which have ticks feeding for a longer period of time. Basically, these data can be thought of as posing, as representing the variable exposure risk across these different regions of the state. And the exposure risk, based on this single factor, is lowest in Nantucket. This is another more recent configuration. So this is, again, showing engorgement rates and the percent of engorged ticks town by town. And you can see again, it's not a nice clear pattern in the other one as in the previous slide, but you can see Nantucket is sort of low on the engorgement rate, and then other towns have higher engorgement rates. So this may guide us in telling where we'd like to target the message to the public about getting these ticks pulled off earlier and not letting them feed so long. There's a caveat here. There's also a sample size. So these are, again, this is passive surveillance. So I'll say one of the caveats of passive surveillance is some of these towns we may have only received 1 or 2 ticks. And so the value of this estimate of engorgement rate is greatly reduced where we receive small numbers of ticks, which again is one of the reasons that we are encouraging people to really think about utilizing the service, because that citizen science component makes the data that we receive that much stronger, and in turn we feed it back to you. When are people getting when are people or pets getting bit by ticks? Well, we know there's a seasonality. We knew this based on just entomological data, going out and collecting ticks, but we see the same patterns for the human biting ticks. Here you see the 2 peaks of adult season deer ticks. Here's the spring, and then again in the fall, showed by the gold, or represented by the gold bars, and then the late spring, early summer peak of nymphal ticks. And the reason this is important is that nymphal ticks are generally thought to be the more dangerous ticks. They have a slightly lower infection rate. Let me say that again. They have a slightly lower infection rate than adult ticks, but they're regarded as having a higher exposure risk because they're more likely to feed for a long period of time because they're that much smaller, if you can follow that logic. So people really worry, public health officials really worry about these nymphal ticks, and knowing precisely when they become the more abundant ticks in an area is very important. And we get that data by quantitating the ticks that are sent to us. And I'll tell you that these data are aggregate for 2014 as part of that study I described before, and that in certain parts of the state, the western part of the state, this switch over from adults to nymphs happens a little bit later than it happens in places like Nantucket, Martha's Vineyard, and Cape Cod. So knowing that information, and it might be different by 10 days to 2 weeks, and knowing that information allows us to make locally strong messaging about when to anticipate that kind of change, and not to be creating a fatigue among the public by saying, oh, we always worry about ticks, it's always equal concern. No, there's actually points in time in the trajectory of any given year when the risks are higher than other times. And so knowing that detailed information broken down geographically is of great value. Where are these tick bites being reported? Well, here in Massachusetts, every single town has sent us at least 1 tick over the past 13 years. And now we can say that every state in the country has also sent us ticks. In addition to knowing where the tick fed, in addition to knowing where the person encountered the tick that bit them and the home address, we try to put the distance, we try to take into account the distance between those 2 sites. I said that in a very complicated way. We look at where the tick bit people, and we look at where people live, and then we try to look at the distance between the 2. Because our interest is to find whether most tick exposures are happening in people's backyards, or whether they're happening when they go on to vacation in some area that might be a particularly ticky spot. So this is a recent summary of the distance between those 2 addresses, the home address and the address as determined by zip code. So there's a qualifier there. The difference between the zip codes, the home zip code and the zip code of where the tick encounter occurred. And you can see a large proportion of the ticks are from that bit people in the same zip code that the people live. But there are a certain percentage that are, they're associated with, my apologies, with great distance traveled between the home address and the site where the tick took place. Now I guess I can go on to that slide. So what this slide is showing you is this is a map of all the ticks that were sent to us as having been encountered in the state of Massachusetts. And then the arrows point back to the site where the home address occurred. So for these ones you can't make out, all the red and yellow ones that are sort of clumped in together here, those are those very short distances. So these might be people from one zip code to a neighboring zip code, or from Massachusetts to a nearby state like New Hampshire. But I want you to look at all these blue lines. Each of those blue lines represents a tick that bit someone in the state of Massachusetts and then returned to their home address in one of these other states. So for example, this one line here explains the one tick that we've received from Hawaii. It was not a Hawaiian tick. It was a Hawaiian resident that visited Massachusetts, returned home, found the tick when they got back home, reported the tick to us, sent the tick to us for testing, but it was actually a Massachusetts tick. That's important to know because it's telling us the rate at which these ticks and potentially the associated diseases are being imported and exported between different states. Let me show you another image of this. This is the same data for the state of California. So this is telling us the number of ticks that were encountered in California and then brought back, for example, to Massachusetts or Florida or Oregon or Washington, or etc. And these data are only available because we're asking people to comment on the tick that bit them and asking them to remember where they encountered that tick. So an office worker in San Francisco that only spent any time in the last couple of weeks in the woods out on Martha's Vineyard, Massachusetts, would know that they probably didn't get the tick in San Francisco. They got the tick in Massachusetts, and they record that when they send in the tick test. These data have been really valuable. In fact, we published a paper recently where we reported that most of the ticks that come to us from California, I backed up a slide here now, but most of the ticks that come to us from California, which are positive for Lyme disease, are actually ticks that came from either the upper Midwest or the northeastern United States, where Lyme disease is endemic. And we know that because we can genotype the ticks. We can look at the DNA sequences of the ticks, and we can trace them back to Massachusetts. So the upshot is a lot of positive Borrelia, Lyme disease positive ticks that are encountered in California are coming from traveling to the Northeast. And that's important to know, that those aren't necessarily endemic cases that are occurring there. It's not to say there's not endemic Lyme disease in California. There most certainly is. It's just to say that it may be overestimated by not understanding where the tick bites took place. Another way we can talk about where tick bites occur, because we actually get information when people send the tick, we ask them where the tick was pulled from, is what parts of the body they feed on. And here you see that distribution. And we can feed this back as well, both to the individual clients, but also to public health agents, and say, well, this is where people are reporting they're finding their ticks. You may want to let people know to look in those areas of the body if they're not already. And what pathogens are encountered? I'm just going to show you 3 slides on this. These are summary slides that are still a bit premature, but sort of hot off the press data. So here's a report of comparing the number of submitted positive ticks that were received, shown in the red line, and then case-wise for the state of Massachusetts, the number of reported cases over the time period January to December of 2015. And what you see is there are 2 peak activities of ticks, one in the spring and one in the fall, and just a single peak of Lyme disease reports in the late spring, early summer. This corresponds to what's long been known, that the nymphs pose the greatest risk. Of surprise to us is that there's not a secondary peak after the adult season here. We don't really have an answer for this yet. We know that the adult ticks, while they're less abundant than the spring adult and nymphal ticks, they do tend to be engorged at the same rate that nymphal ticks are. So the assertion that nymphal ticks feed for longer because they're smaller, at least in our data, we see as many adult ticks feeding for that same length of period, that dangerous length of period, as nymphal ticks. And so we would anticipate a second peak of Lyme disease in the fall. and at least at present it's not being seen. Here's data for similar data for anaplasma, another pathogen transmitted by deer ticks. Again, following the red line, this is submitted ticks, 2 peaks annually, spring, fall, spring, fall, spring, fall. And again, in this case, though, we see a spring and a fall, a spring and a fall, a spring and a fall cycle of reported cases of anaplasma among people. So here's what we would expect to see, that when the ticks are abundant, shortly thereafter, even concurrently, there are incidences of reported cases of the associated diseases. This one is for Babesia microti, so the third pathogen that we talked about in deer ticks, associated with deer ticks in the last webinar. Again, 2 peak distributions for ticks, positive ticks, and a single peak for reported cases of Babesia. We wonder whether this is just being missed, whether there are Babesia cases that are coming on the heels of these secondary peaks of fall ticks that just don't get diagnosed because of the bias towards thinking that the nymphs are the more important reservoirs. Let me just show you, sort of to finish this out, a quick summary of other pathogens. So I mentioned that we don't just test deer ticks, we test dog ticks and Lone Star ticks as well. We test many other species of human-biting ticks, but those are quite rare. What I'd like to tell you is that the pathogens that are associated with non-deer ticks, things like Bartonella henselae has been suggested, Rickettsia rickettsii, the agent of Rocky Mountain spotted fever, Ehrlichia chafiensis, and Borrelia lone star, which is a Borrelia pathogen, or excuse me, a Borrelia species that was initially thought to be associated with disease in the southeastern United States. It now seems that it probably isn't such a serious pathogen, but it is found in these ticks. And yet they're all very, very rare in most reports. And in our hands, we sort of reconfirm this idea that they're very rare. Other laboratories that test ticks report higher instances of these. We really have no way of understanding that because they don't reconcile with our data. We trust our methods. We have no information about other methods that are used by other laboratories. But we've now gone back and screened libraries. You know, we keep all of our ticks as an archive, and we've gone back and screened nearly 24,000 ticks from that library, and we find not a single positive tick for Bartonella henselae, nor Rickettsia rickettsii, which is the Rocky Mountain spotted fever agent. We're not saying that these aren't present. We're saying that in a fairly large sample size, we did not detect them using our highly accurate, highly specific method. And for that reason, we assert that these are relatively low frequency pathogens. And elsewhere, without going into details because we're not talking about peer-reviewed sources, but there are other testing agencies that have suggested that Bartonella henselae may be upwards of 20 or 30% infection rates among ticks. We have no evidence, and any evidence that sort of says otherwise makes us wonder whether their methods are reliably testing what they think they are testing. The last thing I want to sort of wrap up about this, so I've told you about why we test ticks and why we think it's valuable, how we test ticks, how we're utilizing the data. In this little summary of the updates from the Laboratory of Medical Zoology, I'd like to point you back to that webpage and tell you why I think what we're doing is special and goes beyond just being a service laboratory. It's fundamental to our mission to communicate information, and that's based on the best science at hand. And so for that reason, on that order webpage, you notice that we have FAQs, frequently asked questions. So those FAQs, those frequently asked questions, come directly from, they are literally frequently asked questions. They're questions that are posed to us either through phone calls or people that visit the laboratory or our online chat tools, where when we see a question that comes up again and again, then we put it on the FAQ and we try to give a responsible answer for it and point people to the appropriate references for that. We also provide statistics of every tick that's tested for us. So I won't show you an example of this today, although if you go to tickreport.com/stats, STATS, or just go to the web page and click on that statistics page, you'll be asked to sort of sign an agreement that you're not going to use the data for nefarious purposes. There's no private information there, but we just ask that you not publish it without, getting special permission from us or getting permission from us. But if you go there, you can see the summary of all the ticks that have been sent to us since 2006 and what the test results are, sans any personal information. The reason I'm not showing it to you today is that I hope by the next webinar I'll be able to show you a very updated version of that. So when you go to the stats page, you'll find that the search tools are sort of limited. The representation is a little bit clunky. We hope very soon to have a much more visually friendly and frankly more visual representation of that data, and I'll probably talk to you about that in future updates. But the point is, the data that we're collecting is we're giving that back to the public. It's used by our colleagues in some cases that are seeking to publish those data as part of their studies, related studies. Other cases, it's being used by state or local health agents to communicate their message to their constituencies. And then, of course, we hope that individuals that, for one reason or another, either they've not been bitten by a tick, or they've been bitten by a tick and elect not to test that tick, that they will see the statistics resources as a way to gain the information that's being collected or being supported by their neighbors and benefit from that information even if they choose not to participate themselves. So if you can see information about, in the tool you'll see you can search your zip code and look for all ticks submitted from your zip code. If you can benefit about understanding the risk from your zip code and use that to keep yourself and your family safe, well, that for us would be is a real win, that you can put these risks in a context that you can take appropriate actions. And then lastly, I point out, I've already alluded to it, but because we want to make sure that people understand the results that they get from their tick report, several years ago we created this online chat tool which you can link to in the corner of the page. I have the red arrow there highlighting it. And coming up in a couple of weeks when well, we're already into a pretty active tick season, but in the next couple of week or two, we'll be running that service from 9 a.m. to 9 p.m. We currently run it basically during business hours during the week, but we'll go 9 a.m. to 9 p.m. when we get into the full throat of spring tick season. And that's an opportunity for you to get on and speak with our trained personnel to ask questions about ticks, tick-borne diseases, tick testing. We don't engage in conversations about treatment therapies. We let your doctors and your nurses and your PAs do that. But we are happy to answer questions to the best of our knowledge about everything on the prevention side of ticks and tick-borne diseases. And that's the tool that we've created to make that information. So you can communicate in real time with a real person who's it might be a student that we've trained, or it might be myself on the other end of that line trying to answer your questions. Because our goal really is to make people aware of the fact that the protection from tick-borne diseases, that mitigating that risk is a three-step process, that you don't need to just worry, or you need not think that you're only constrained to worrying about what happens before the ticks get on you. You also have opportunities when the tick has bitten you and after the tick has bitten you to assess how serious that risk was, and then to make future decisions about what you're going to do to avoid further risk. The last point I want to make about this, and last slide I'll say, is just I'm borrowing this figure directly from Dr. Alan Steer's publication from 2004, where he describes the events that might take place after, or the actions that might be taken after a series of summer events associated with a tick bite. Excuse me. So you see along the top, here's a couple of different scenarios. You could have a tick bite, you could have a skin rash, you could have a summer flu, and then he's worked out a flow chart for what you could do in the case of a tick bite. And he basically regards tick, diagnostic testing. So going to your doctor and getting a blood test, maybe it's not necessary. You can just go and get an oral therapy of doxycycline, either the prophylactic or the treatment of. And some docs do this. I'm not speaking to medical practice, I'm just reporting Steer's paper here. Or in the case of a skin rash, you might do the same thing, or a summer flu, do the same thing. Skip the test, just expect the worst and maybe treat with a therapy. Or you can use the option of doing this two-stage tick test, or excuse me, diagnostic test. When he says no test here, he's referring to no human diagnostic test. My argument is that this would be an ideal place to consider, if you have the tick, having the tick tested to understand the risk. If there's no way, and one of the reasons you wouldn't bother to test the human is that it takes a while for the antibodies to arise, and so human testing isn't valuable in the first couple of days of post-exposure. But at least consider the benefits of possibly testing ticks to understand the associated risks. And for the other events that he talks about, which might be associated with other pathogens within those same ticks, well, there I would argue that TickReport might be even more valuable, because in some cases those other rarer pathogens, things like Ehrlichia chafiensis or Borrelia miyamotoi, they may not even be on the doctor's radar screen, and so he or she may not even think to start along that diagnosis unless given information like an independent tick report that suggests there was such an exposure. So we're not practicing medicine, we're not diagnosing people, we're not encouraging people to think that this is a diagnosis. We think it is a very valuable tool. TickReport is a very valuable tool for people to be able to assess their risk, to communicate with their doctors, to understand their doctors better, and in some cases, frankly, for doctors to understand the patient's concerns based on those risks of exposure. And so we're hoping to empower individuals in that way. And all of this is possible, or all of this is strengthened by our tick lab, but also by our outreach program, which in the interest of time, I'll just quickly go through this slide, get quickly to the announcement that our next webinar will be a month from now. It's at the same time, same place, same tick time, same tick place, and that you can go on and register. I'm going to be talking about American dog ticks and Lone Star ticks and some of the associated diseases. You can see this, look at this slide yourself. I want to just quickly also tell you that TickReport is coming to Eastern Massachusetts. So you may be aware that now UMass has a campus in Newton at the former Mount Ida College campus, and that the Laboratory of Medical Zoology, we are going to be visiting that campus on the 15th of May for an evening presentation, basically a live presentation of what we talked about today. It's probably going to be a 90-minute presentation. I'm going to talk, we haven't secured all the other speakers yet, so I'll refrain from that, but I'll say there will be some high-profile speakers to present other aspects of this, and we'll also be on hand to answer questions. And that will be in Newton, Massachusetts, at the Newton Mount Ida campus. We'll give updates on ticks and tick-borne diseases, and if you have information about that event, just email us at info@tickreport.com, and we'll give you updates as they become available. The date is solid. It's 15 May 2019. It'll be an evening event, probably 6-ish. That's a Wednesday, probably a 90-minute presentation, or 90-minute event, which would probably be a little bit of talking at the beginning and then lots of opportunity for answering your questions. So I thank you again for your attention. I'm sorry I went a little bit long today. Hopefully most of you stuck around and find these webinars beneficial. If you want to give feedback to us, I'm not able to really to see your questions in real time, but again, use info@tickreport.com, or better yet, go on that TickReport webpage and use the chat icon and ask your questions there. If you happen to log on to that chat tool off hours, it will go to email and we'll respond as soon as we can. So there's lots of ways to get in touch with us, and we want to be accountable and responsive to all your questions. So thank you very much, and I hope to see all of you in another month.
Thank you, Dr. Rich. Sorry we don't have time for questions. So again, as Dr. Rich has said, if you have questions, please try to get those questions through the TickReport website, or you can email him questions. So again, thank you very much, Dr. Rich. And for those of you who are still on, if you could still fill out that survey before you exit, that would be appreciated. Thank you very much. We'll see you in May for the next webinar.